It's like a constant war, and you wanna settle that score, but you're bruised and beaten, and you feel defeated. This goes out to the heaviest heart. Oh, to everyone who's hit their limit, it's not over yet, it's not over yet. And even when you think you're finished, it's not over yet, it's not over yet. Keep on fighting, out in the dark, into the light. It's not over, hope is rising. Never give in, never give up, it's not over. Yeah, whoa. Oh, game, set, match. Time to put it in your past. Oh, feel the winter leaving. It's redemption season. Long live the young at heart. Cheers to a brand new start. We're revived and breathing to live a life of freedom.
Now, welcome everybody to our webinar series, Yes, ILAE. Today we have the honor of being with Professor Emilio Perucca. Professor Emilio Perucca has trained as a neurologist and clinical pharmacologist at the National Hospital for Nervous Diseases in London. He is currently past president of the ILAE, professor at the University of Pavia in Pavia, Italy, director of the Clinical Trial Center at the Mondino National Neurological Institute in Pavia, and adjunct professor at the Department of Neuroscience in Monash University, Melbourne, Australia. He is a member of the editorial board of several journals, including Lancet Neurology and CNS Drugs. He received various awards, including the ILAE IB Ambassador for Epilepsy Award in 1997 and ILAE European Epileptology Award in 2018. Dr. Perucca's research activities have focused on the drug treatment of seizure disorders and assessment of outcome in epilepsy. He authored over 500 PubMed-listed publications with an H-index of 83 and a citation index of 28,000. Today, he will be talking about antiepileptic medications in adult epilepsy. We have the following learning objectives. And now we have the honor of having Dr. Perucca with his talk. You can start now.
Okay, thank you, Manuela. And I understand that this webinar is being followed in different parts of the world, not just in Latin America. So good afternoon and good morning, wherever you are while you are watching this. It's a privilege to be invited to have this webinar for the YES community. I wish we could have eventually an actual meeting, because all of us, I guess, are a little bit fed up of virtual education, and there is nothing really that replaces live contact. But unfortunately, it will be some time before that. So let's move on and go into the topic, anti-seizure medication and their use in adults. I start by just showing you my disclosures and a disclaimer, meaning that I will be discussing indications of value of medications in different conditions, which may not necessarily correspond to the indications and the labeled use of these drugs in the countries where you practice. So you should be checking prescribing information before using these medicines wherever you practice. The reason for showing this slide is that just to point out, and all of you know that we have many drugs to treat epilepsy. And the situation is very different from the time when I started myself into the field. And I was a young neurologist working at the Center for Epilepsy near London at that time. And the only medications that I had available at the time were those that are shown in black in this slide. So life was easy for me because I only had a little more than a handful of drugs. And because I was working in a center with people with severe epilepsy, I could say that virtually all my patients had already tried all the medications that were available. Today, even a lifetime may not be sufficient to try the medications that are available today in the different possible combinations at least. So how do we pick drugs in clinical practice, considering that the choice is so vast? And it's relatively simple, if you will. We need basically to consider the properties of each of the individual medicines, And we have to do that based on the available evidence. And this is what we will be discussing briefly in this presentation today. Then we have to consider how those properties are likely, when the medication is given to people, to influence their probability of becoming seizure-free. And not just seizure control, but also well-being. And this is to point out that, as we all know, the primary goal of epilepsy treatment is control the seizures completely, but not at all costs. For example, the adverse effects of medications can be so important as to affect sometimes quality of life more than the seizures. So well-being, a good quality of life is the actual goal of treatment. In most cases, that will imply being seizure-free, but also, as I said, controlling the adverse effects. And then what we have to do is to eventually choose the medication whose properties provide the best match for the characteristics of the individual. So tailoring the choice of the medication and go even beyond that, tailoring the dose of the medication to the needs of the patient. And what I've done in this slide is just list the main properties that we should take into consideration when considering the choice of a medication for an individual. And I started by saying approved indications because in epilepsy, we often prescribe drugs off-label, especially in children. We are not discussing children today. But whether a drug is approved or not by regulatory authorities in your countries for a specific indication can be important. Can be important, first of all, because in some countries, only if a medication is prescribed according to approved indication will be reimbursed by the National Health Service, for example. And there are also potential liabilities if an untoward effects develop in a patient if a drug has not been prescribed according to approved indications. So keep that in mind, though of course there are situations where you may need to prescribe drugs off-label. Then we need to consider the spectrum of efficacy. A spectrum of efficacy means whether the medications that you have are going to control the different types or the specific type of seizures that the patient has. And you also need to consider if there is more one drug that is effective against those seizure types, the magnitude of efficacy. Is any of those drugs more efficacious than the others? So this also needs to be considered. Adverse effects, very, very important. We know drugs differ in their adverse effects. And again, we have to consider how potential adverse effects could impact individual patients based, again, on the characteristics of the patient. To give you one example, certain medication can cause weight loss, but that may not be necessarily a bad thing if you're treating someone who is obese. That may be particularly problematic if you're treating someone, on the other hand, who is thin. And then the impact on comorbidities, and the example that I just given tells you how that also impacts on treatment choice. We have medications that can improve some comorbidities, and we also have medications that can worsen some comorbidities. So this, again, needs to be taken into account. Drug interactions are especially relevant when we prescribe drugs in people who are taking other medications. And the best situation, the best example of that is the elderly. Typically, when epilepsy starts in old age, these people have a lot of comorbidities. They are taking a lot of drugs, and we need to consider potential interactions when we prescribe an anti-seizure drug. But also consider that drug interaction can affect can impact on outcome, even when we prescribe drugs as monotherapy. For example, we may prescribe a drug in a young girl, and later on we have to consider that the girl may wish, for example, to take a contraceptive steroid, or we may think that there can be intercurrent conditions coming up. So it's a consideration again. The mechanism of action is something that I don't put at the top. We don't generally prescribe drugs in epilepsy based on mechanism of action. I guess when you make a diagnosis of epilepsy, you don't come up with a statement like, okay, this guy has a kind of epilepsy that needs a sodium channel blocker, or this guy needs a medication which is SB2A modulator. This is not the way we prescribe drugs in epilepsy. And this differs, for example, from other fields of medicine, where, for example, when you prescribe an antihypertensive drug in people with hypertension, you may say, okay, this patient will need, for example, a calcium antagonist, but this patient will do well with an AEC inhibitor. This is not the way we do in epilepsy, but there are some situations where knowledge of the mechanism of action is important for selecting medications. And I will be saying a few words for this. And then ease of use is a little bit something which encompasses many of the points that I have already made. If a drug is broad spectrum, highly efficacious, has not many adverse effects, not many drug interactions, will be easier to use than a medication that has a narrow therapeutic index and have a lot of adverse effects. However, ease of use also takes into consideration other things. For example, can a drug be given once daily compared to more frequent administration? Is there a convenient formulation available? And this is especially relevant in pediatric age that we are not discussing right now. Is a drug requiring a special and complex titration? Lamotrigine, of course, it would be an example of that. Lamotrigine is a very valuable drug, but it's not an easy to use when you start treatment because of the complex titration scheme, etc. So ease of use is more than just efficacy and adverse effects and spectrum. And cost, of course, is another consideration that we need to make wherever we live. Cost either to the individual or to society. So let's consider briefly each of these properties, starting with the spectrum of efficacy. And what I have done in this slide, it's a little bit of an oversimplification. I acknowledge that, but I classified medications into three groups. Here on the right, ethosuximide stands alone because ethosuximide is basically a drug which only works against absence seizures. Might have some value perhaps against myoclonic seizures in some patients, but basically it's relatively selective for absence seizures. And then in the middle, I have a number of drugs which, especially if you are a non-specialist, I would suggest you only use these drugs in people with focal epilepsy. Some of these drugs may also be valuable. For example, phenytoin and carbamazepine can also be valuable in some people with primary generalized tonic-clonic seizures, also some other syndromes. But we need to consider that many of these medications are potentially aggravating in people with generalized epilepsies, especially idiopathic generalized epilepsies, where carbamazepine, phenytoin, or scarbazepine, carbazepine acetate, etc., can, for example, trigger or worsen absence seizures and myoclonic seizures. So there is a risk of seizure aggravation with some of these medications when they are prescribed to people with generalized or combined focal and generalized epilepsy. And then on the left, we have what I call it the broad spectrum drugs. Although I put down fully or partly broad spectrum because, at least in my interpretation of the evidence, there are only two drugs that are entirely broad spectrum. And those are valproate, which virtually works against any seizure type, and benzodiazepines. Although benzodiazepines, because of their issues with tolerability and tolerance to some extent, they are not generally first-line medication in people with epilepsy. But valproate and benzodiazepines are throughout broad spectrum drugs. Phenobarbital is broad spectrum, but for example, does not work against absence, may even aggravate absence seizures. Primidone is very similar to phenobarbital, of course. And then in red, what we call the second generation drugs. And levetiracetam is a good drug for focal seizures, for generalized tonic-clonic seizures, for myoclonic seizures. Is not a specific, it's not a good drug generally for tonic or atonic, for drop attacks in people with epileptic encephalopathies. Is probably a weak drug if it works at all against absence seizures. Lamotrigine has some efficacy against absence, is not generally, instead of, unlike levetiracetam, is not generally a good drug for myoclonic seizures, can even aggravate myoclonic seizures in some patients, but it is a valuable drug for example, drop attacks associated with Lennox-Gastaut syndrome. Topiramate, again, relatively broad spectrum, but a fairly weak drug if it works at all against absence. Can also work, topiramate, against drop attacks. Zonisamide has been mostly evaluated in Japan. Best evidence is for its efficacy against focal seizures, but a number of especially open label uncontrolled studies suggest that it works against myoclonic seizures and other seizure types, including absence. Carampanel, the best evidence that we have so far is for focal seizures and primarily generalized tonic-clonic seizures. Its potential value in other seizure types is not established yet. And the same applies for lacosamide, which has been shown in randomized controlled studies to be efficacious against focal seizures and against generalized tonic-clonic seizures, but we do not have data against other seizure types. You may have noticed that some drugs from the early list were missing in the previous slide. And I'm not going to discuss these drugs today because these drugs are mostly used for pediatric epilepsies, and we are not discussing the pediatric epilepsies today. However, we do see people with Lennox-Gastaut syndrome who are adults. So somehow people with tuberous sclerosis who are also adults, etc. So there also can be a potential for using some medications in adults with these conditions. But I don't want to spend much time. You can read that for yourself. And they call this medication syndrome specific because their utilization has been mostly evaluated in clinical trials which have been organized by syndrome. Rather, the previous slide shows drugs where evidence is mostly derived from studies done where patients were recruited according to a specific seizure type. So let me review now the magnitude of efficacy of these medications in those conditions where more than one medication has been found to be efficacious. And let me start with the first generation drugs first. And I'm showing you the results that many of the older neurologists will remember very well because it's been one of the really pivotal milestones in evidence-based medicine of epilepsy. This study done many, many years ago by Dr. Matson and his co-worker from the VA collaboration in the US, where they looked at people with newly diagnosed or previously undertreated, this is not a minor detail, focal epilepsy. And they randomized these people to 4 medications that were really the 4 major medications available at the time: phenytoin, carbamazepine, phenobarbital, primidone. And they followed them up over time. And they looked at the proportion of patients continuing on treatment, which is a combined measure of efficacy and tolerability. You will remain on the allocated treatment if your seizures are controlled, of course, and if you tolerate the drug. And you can see that there were 2 winners. In terms of retention on treatment, phenytoin and carbamazepine. Phenytoin is the black circles and the open circles on carbamazepine. They did almost the same in terms of retention. And phenobarbital and primidone did not do that well. On the other hand, in the subgroup of patients who had bilateral tonic-clonic seizures, so focal to bilateral tonic-clonic, phenobarbital was as efficacious as carbamazepine and phenytoin in controlling the seizures. Primidone did worse in all patients, partly because of lesser efficacy against focal seizures, but additionally worse tolerability than phenobarbital. Largely, I have to say, due to an excessively fast titration rate at the beginning of treatment. A subsequent study done by the same collaboration compared carbamazepine with valproate against focal epilepsy. And I modify slightly the original slide by using modern terminology. So there was one group of patients who had focally aware seizures. And in this group, and what this shows that again, the retention at 12 months, carbamazepine, which is the square over here, did better than valproate. Whereas when you look to focal to bilateral tonic-clonic, and these are the two curves here, it goes down a little bit here, but basically carbamazepine and valproate in people with focal to bilateral tonic-clonic seizures were similarly effective. But overall, the prevailing evidence is that valproate is not as efficacious as carbamazepine and some of the other drugs that have been developed more recently in controlling focal seizures. But the efficacy overall is pretty similar. One issue with valproate, though, is that if you use it for focal seizures, to control the seizures, you need to use higher doses than you do when you treat, for example, idiopathic generalized epilepsies. And so valproate is really not so well tolerated in its use to treat focal epilepsy. And of course, it would not be an option, given all the other drugs that we have these days, to treat focal epilepsies in women, at least in young girls or women of childbearing potential for obvious reasons. Now, what about the second generation drugs? And what I've done here is summarize the many studies that have been done comparing a number of second generation drugs, and you find the names here. I'm not just reading the names, but you find many second generation drugs. All of them were compared with carbamazepine in, I have to say, well-designed, randomized controlled studies in adults with focal epilepsy. And the overall results were that none of these drugs were found to be more efficacious than carbamazepine, which was mostly the drug they were compared with. At best, they had very, very similar efficacy. And that was true for levetiracetam, was true for lacosamide, has been true recently for lacosamide, zonisamide, carbamazepine acetate, etc. There were actually some of the second generation drugs, which in these studies have been found less efficacious than carbamazepine. That's definitely true for gabapentin, and is also true for vigabatrin, although vigabatrin is no longer used for focal epilepsy these days because of its problems with potentially severe visual field effects. There was one large study, and I'm showing you only one of such studies that was done in the UK, comparing in people with newly diagnosed epilepsy and mostly focal seizures. The design of the study was a bit complex, but I'm simplifying here. So people who had mostly focal epilepsy were randomized to receive carbamazepine, which is the purple line here, or lamotrigine, oscarbazepine, topiramate, and gabapentin. You see the data here up to a follow-up of 4 years, which is up to the point there was really a sizable population in each of the groups. You can see almost 2,000 patients were randomized in this study. And you can see that basically all these drugs did pretty similar in terms of response. This is again probability of remaining on treatment, combined measure of efficacy and tolerability. Lamotrigine, oscarbazepine, doing fairly similar to carbamazepine. Topiramate slightly less well, partly because of tolerability issues, and lamotrigine and gabapentin doing worse. Gabapentin is the red down here. Gabapentin did not have a good retention. And this was not due to tolerability. Gabapentin was very well tolerated. It was due to efficacy, seizure control on gabapentin not being as good as with the other drugs that are shown here. There was a subsequent study that has looked at carbamazepine, lamotrigine, and levetiracetam in focal epilepsy with onset in old age. I'm showing this because there have been many studies in people with epilepsy with onset in old age, and the results are a little bit different in these people compared with younger people, because we know that people in old age are more sensitive to the adverse effects of medications, and in fact, generally they require lower doses to have those doses sufficiently well tolerated. On the other hand, a good thing is that epilepsy with onset in old age also has a more favorable response in terms of efficacy to medications. So we can control this epilepsy fairly well with relatively low doses. And carbamazepine in general is been found not to be as well tolerated as specifically lamotrigine and levetiracetam, and probably other drugs, though some of the second generation drugs has not been so well tested as lamotrigine and levetiracetam in this population. So this would be perhaps a subgroup of patients where lamotrigine clearly does not do as well as second generation drugs. Additionally, lamotrigine and carbamazepine would not be, generally speaking, a good choice to treat epilepsy in the elderly if you have other drugs that can be done available or can be afforded, because as I said earlier, elderly people take a lot of other drugs for comorbidities, and the potential of drug interactions, especially due to enzyme induction with carbamazepine, is significant. I'm showing you the results of, again, going back to the British study that had another arm with 700 patients in that arm. And that arm included mostly people with generalized or unclassified epilepsy. So for people with generalized epilepsy, unclassified epilepsy, we use generally medication with a broad spectrum. And in this case, valproate, lamotrigine, and topiramate were compared. And here, the results are rather different compared to the results seen in focal epilepsies. Here, there was a clear winner, and the winner was valproate in terms of retention, which is the line here at the top. Lamotrigine was inferior to valproate in terms of retention, and the topiramate did worse than both valproate and lamotrigine. The reason for lamotrigine not doing so well as valproate was not because of tolerability problems. Lamotrigine was well tolerability, but because it was not as efficacious as valproate in controlling the mostly generalized seizures. Topiramate was efficacious, but did not have the tolerability of the other two drugs. And the poor results with topiramate are mostly due to the occurrence of intolerable adverse effects. That study, that British study, the name is SANAD actually, looked at medications that were mostly used when the trial started, and those medications did not include levetiracetam. So the study has been repeated, comparing levetiracetam with valproate in people with generalized or unclassified epilepsies. And the results have not been published in full, but they've been presented in International Epilepsy Congress last year. So I have tabulated the results for you to peruse. The 520 patients were included in this study, and the slide shows different outcomes. I hope you are familiar with this way of presenting results: confidence limits, 90% confidence limits, and point estimates for time to treatment failure. If we are on the left of the identity line, it means valproate was better. If we are on the right, it means levetiracetam was better. And as you see, for all endpoints, time to treatment failure, time to first seizure, treatment failure due to adverse events or to inadequate seizure control, levetiracetam did not do well as valproate. There was no difference for adverse events, but for efficacy, levetiracetam was inferior. And if you look down here at the bottom, you can see that on several other endpoints of efficacy, and levetiracetam was not just as efficacious as valproate. There was one large study, which again, I will not spend much time because it's, of course, pediatric, and I'm not dealing with pediatric epilepsies, but for completeness, I just want to remind you that there's been actually an excellent, well-designed study that compared valproate, etosaximide, and lamotrigine in newly diagnosed childhood absence epilepsy. And valproate and etosaximide were similar to each other in efficacy, but superior to lamotrigine. And there was also another study that we actually did at our center a few years back in people with newly diagnosed absence epilepsy, that also included some people with juvenile absence epilepsy, not just childhood absence epilepsy. We gave them placebo only for 2 weeks because the people only had absences and never had any generalized tonic-clonic seizures. We felt it would not be unethical for a very brief period to give placebo, and we put up very, very fast the dose of levetiracetam, and there was a marginal, not significant difference in favor of levetiracetam versus placebo. And then everyone went on to receive levetiracetam. Some children did well, some did not, but overall the impression, and even this data, strongly suggests that levetiracetam is really not a highly efficacious drug in controlling absences. So the conclusions in terms of efficacy, there is no anti-seizure medication that has shown superior efficacy to carbamazepine in focal epilepsy or to valproate in generalized epilepsy. And unfortunately, we do not have adequate evidence for comparative trials in most generalized epilepsies. The trials I've shown you pulled together people with different types of generalized epilepsy. And we would like to have a trial in JME, we would like to have a trial in the different syndromes. And those trials have simply not been done except for childhood absence epilepsy, which is why I've shown you those slides from the previous slide. And also we have actually have no study that has ever compared different medications according to a randomized double-blind design in patients with developmental and epileptic encephalopathies newly diagnosed. All the trials done have been adjunctive therapy in people with refractory epilepsies in this condition. Moving on to discuss adverse effects. We know that all medications have adverse effects. And this slide taken from some early work from my friend Martin Brody many years ago shows us that about 5% of newly diagnosed patients started on medications, discontinue it because of idiosyncratic adverse effects, mostly skin rashes and sometimes more severe allergic reactions. And another 7 to 20% discontinue because of dose-dependent, mostly CNS adverse effects. And you will see that overall, the proportion of people discontinuing due to dose-dependent adverse effects is higher in people with structural metabolic, mostly focal epilepsy, than in people with genetic. Here, genetic really means mostly idiopathic generalized epilepsies. And the reason is that idiopathic generalized epilepsies respond generally to low doses, relatively low doses of medication. People with these epilepsy, structural, metabolic, focal, or unknown, generally require higher doses. So these people don't achieve good seizure control, we increase the dose, and then we run into mostly CNS adverse effects that require discontinuation of treatment. I also want to point out that we should not overemphasize this. And this slide is taken from Emilio Perucca, is not actually myself, is a close relative of mine who is currently working in Australia, who was working at the time in the United States when he did this work. And he pulled together, together with our colleagues, data from 2 different studies, one done in the UK and one done in the US. And this study was done, these data were taken from a randomized studies in people who had newly diagnosed epilepsy, but there was uncertainty on whether treatment was indicated or not. For example, because there was only one seizure, or because the seizures were rare or only during the night, and or the patient was reluctant to start medication for a variety of reasons. So there was uncertainty really whether the treatment should be initiated or not. So these patients agreed to be randomized to two groups, one group to receive the medication and the other group not to receive medication. And they were given a questionnaires for adverse events. And after follow-up, the magnitude of adverse events on a standardized questionnaire did not differ between people on no treatment from people on anti-seizure medications. And this tells us that we give a medication to people, they complain they feel tired, they complain they have a headache, but we also feel tired at times and we don't take an anti-seizure medications, or at times we have a headache. But if I'm giving an anti-seizure medication, I feel tired, then I say, okay, it's because the doctor is giving me that drug. But a lot of adverse experiences in our lives are not necessarily due to the medication that the doctor is giving to us. And this is the point. I find this slide very useful to discuss with patients, because some of my patients are very worried when they are given a diagnosis about the side effects of drugs. Generally, they already suspect the diagnosis before they come to you. They went from the internet, they already know all the drugs and all the side effects of the drugs. And to reassure them, to say, you know, it depends on the dose, we will see how it goes, but these medications are generally very well tolerated most of the time. And this is good data to support them. Of course, we know that this medication can cause very severe side effects. And this slide is taken from some work that we did some time ago, looking in this case at almost, well, actually more than 800 consecutive patients with uncontrolled seizures. And because they had uncontrolled seizures, these patients were on a high burden of medications. Actually, 3/4 were on combination therapy with 2 or more than 2 anti-seizure drugs. And what the slide shows is that the relationship between the score of toxicity on the standardized questionnaire and the quality of life. And when you have a score which goes above 45, 50, it means really a patient is experiencing a lot of adverse effects. And you can see in this slide, really about more than about 1/2, almost 1/2 of patients had very severe burden of toxicity. And the higher the burden of toxicity, the lower was the quality of life. When you have a burden of toxicity of in around 70 or 80, your quality of life drops to almost 0. So in people with uncontrolled seizures, it's actually the burden of side effects that affect the quality of life more than the seizures themselves. And I'm showing you here from the same patients, the relationship between seizure frequency and quality of life. And this is the square root. So 10 means 100 seizures per month, or 1 means 1 seizure per month. And yes, 100 seizures per month, you have a lower quality of life. But really, the data are all over, and the relationship is very poor. So in these people, it's not the seizures, but it's the side effects of drugs that determine quality of life. So if we cannot control the seizures, we should not overburden, overtreat our patients, remembering data such as these. You learn, you read at times that second-generation drugs are better tolerated. I think this is an oversimplification. I don't think that's the right way to place the statement. It's a very artificial question. Depends which drug, depends which dose, depends on which patient you're treating. We know that second-generation drugs can produce very serious adverse effects. We know that each drug differs from others in adverse effect profiles, indications, contraindications. So we need to select treatment according to the individuals, and none of the first-generation drugs is actually obsolete. One area where there are differences in terms of tolerability, actually safety, between first and second-generation drugs, especially one first-generation drug, is teratogenicity. And this slide shows data from 3 different registries. So the circles are the Europe International Registry, The circles are the triangles are the North American registry, and the squares are the UK and Ireland registry. And you can see the data across the three registry for all the drugs are very consistent. There are some differences, of course, but they're rather consistent. The drug which causes the most of the problems is valproate. We know that in terms of with a risk overall of about 8–10% risk of major congenital malformations. Second is phenobarb, that you can see here. And then you have three drugs, topiramate, carbamazepine, and phenytoin, which are somewhat in between. And then the three drugs which seem to be safest, according to the registries, are levetiracetam, lamotrigine, and oscarbazepine. By the way, you will notice that the Europe registry, so the circles, almost all the time, I think 99% of the times, gives higher malformation rates than the other registries. You may wonder why. There is, I think, a simple explanation. Europe is the only registry that follows up the babies for 12 months. And some congenital malformations are not picked up at birth or not immediately. Some cardiac defects, for example, are picked up later during the first year of life. So this explains why the Europe registry has somewhat higher malformation rates than the other registries, but the data are fairly consistent. Now, there is one important point which is missing in this slide, is that we are considering malformation rates as a function of the choice of medication. But the choice of medication is just one factor that affects tolerability and adverse effects. The other factor is the dose of the medication. So what about the dose, not just the type of medication? And for some medications, especially those for which we have large data set, we can clearly see that there is a dose-response relationship. And this is especially marked for valproate and for phenobarbital. So if you look here, if you take a dose of valproate of 1,500 milligrams or more, the risk of malformation is dramatic, striking. 1 baby out of 4 will be malformed. But if you're taking 600 milligrams, 650 milligrams or less, well, the risk of malformation with valproate is not that much greater compared with a high dose of carbamazepine or even a high dose of lamotrigine. And with phenobarb, again, a dose higher than 130 milligrams will produce a risk of malformation much, much greater than a dose of phenobarbital or 80 milligrams or less. And also for lamotrigine, there is some dose dependence. There is for carbamazepine, of course. There is no dose dependency for levetiracetam. Levetiracetam does not, the risk does not seem to be dose dependent. And by the way, if you look at the numbers, for example, look at valproate, 650 milligrams or less. 600 women were taking that dose. So it means that significant proportion of the female population could be managed on a low dose of valproate. This does not mean valproate should be used as first choice in this population, but it means that the dose dependency should be one of the factors to be taken into account. The data that I've just shown you has influenced prescribing patterns over the years, and this is why, and this is what is shown here, over the years, and this is data from Europe, overall, taking all the numbers of women included in the registries, so this is not one drug, this is all the women in the registries. In the early 2000s, 6% of babies were malformed. 2010 to 2013, this is the last analysis that we have done, a bit more than 4% were malformed. So there was almost 1/3 reduction in teratogenicity. And when we looked at different analyses of the data, they all pointed to one factor being responsible for this decline, and this is the declining use of valproate in female of childbearing potential, and also the use of lower doses in female of childbearing potential. So this shows you the importance of this data for outcome. I will come rapidly to an end, saying a few words about drug interactions, because we discussed that. And we have to remember that some of the first generation drugs, phenytoin, carbamazepine, and barbiturates are strong enzyme inducers. And then we have some of the second generation drugs, which also have some enzyme induction. Those are shown here. And then there are a number of medications which are enzyme inhibitors. And probably the most important of those is valproate, because all of you know, I'm certain, that valproate inhibits the metabolism of lamotrigine. And valproate also inhibits the metabolism of phenobarbital and pushes up the levels of phenobarbital. And it does interact with a few other drugs. So we know these days how to predict, how to manage these interactions, and I'm not spending much time on this because it would require a separate discussion. But just to remind you that enzyme induction is not just interactions, but also is a cause of iatrogenic disease. For example, it can be one mechanism responsible for disturbances in vitamin D deficiency, osteoporosis, and increase in fractures in people with epilepsy, alterations in serum lipid profiles, and increased risk of cardiovascular mortality, disturbances in steroid hormones, endocrine, and perhaps also some of the disturbances in sexual function related to this mechanism. I think I skipped this for reasons of time. And just say a few words about pharmacodynamic drug interactions, because these are not related to a change in blood levels of the drugs. These are interactions which occur at the site of action, and they can be additive, synergistic, or antagonist. And they are important to know about them, because there is increasing evidence that combining drugs with identical mechanism of action may not provide major benefit and may increase the risk of adverse effects. So generally speaking, that it can make sense to combine drugs which act by different mechanisms. And in the same way, if you have started medication on a calcium channel blocker and that patient did not respond at fully effective dose, normally fully effective dose of a calcium channel blocker, you may consider the second choice not another sodium channel blocker, but a drug acting by a different mechanism, or vice versa. If you started a patient on levetiracetam, you may consider a sodium channel blocker rather than another drug acting for the same mechanism. And maybe when you watch this on YouTube, you can stop this slide at this point and look at the different mechanisms of action of the various drugs. I just want to remind you that we have a number of drugs that are all shown here that are sodium channel blockers. And combinations of these drugs do not seem, generally speaking, you can use them, they are effective in some patients, but they're more likely to cause CNS problems, adverse effects, compared with combination of drugs acting by different mechanisms. And this is one study that has come up with such conclusions. I could show you many of such studies. In this case, what they found is that combination of drugs acting with different mechanisms showed greater effectiveness as measured by retention of treatment and also lower risk for hospitalization and emergency department visits. And this is one example of interactions which have not been found to be especially favorable. And what the slide shows basically is these are all interactions which are combinations of drugs acting by blocking sodium channels, or in this case, levetiracetam or brivaracetam acting on the SV2A receptor site. And I'll keep this and I'll skip that, just to show you one example on the other hand, perhaps the best example of a combination that seems to be synergistic. And that is the combination of valproate and lamotrigine. And there have been many studies suggesting, more than suggesting, I would say indicating, that patients that have not responded to maximally tolerated doses of valproate or lamotrigine given alone may respond well to the combination. In this specific study, valproate was added on to lamotrigine or to carbamazepine or to phenytoin, and the best response was when it was added on to lamotrigine. And this was not due to a pharmacokinetic interaction, because the dose of lamotrigine that went, the dose of lamotrigine was adjusted to keep unchanged lamotrigine levels. Of course, if you add lamotrigine to valproate, you will have high doses or high concentrations of lamotrigine compared with adding lamotrigine to carbamazepine. But this was not the explanation for these findings. So I think I close here because I want to reserve some time for discussion. So we have now 30 different anti-seizure medications, which is a good thing because I've given you a glimpse that these medications are different. And having different medications, we can now tailor better the treatment to the needs of each individual. There is another side of the coin, I would say, that for the super specialist, as many of you are, is perfectly fine to know everything about 30 different drugs and to use these drugs beautifully. But if you are a non-specialist, if you see not so many people with epilepsy, you have to treat so many other neurological conditions, or if you are a GP or a healthcare professional in some countries where you have to treat everything, not just epilepsy, well, being knowledgeable about so many of these drugs can make their optimal use difficult and challenging. So this is something to be considered. And I think we all agree that there are still major unmet needs in epilepsy treatment, because we know that despite of having so many drugs, still about 1/3 of people with epilepsy do not achieve complete seizure control. And this is the same as in the old days when I was practicing in my Center for Epilepsy outside London. 1/3 of people were drug resistant then, 1/3 of people are drug resistant now. We have not gained that very much. So we need more efficacious drugs. We need safer drugs. We need a valproate that can be used safely in women, for example. We don't have that. We need drugs that can impact on the underlying disease. We need anti-epileptogenic or disease-modifying drugs. And this is another area where efforts are ongoing to develop better medications. And this is my last slide, which gives you a list of compounds in clinical development. The list is not complete. There are many other drugs that for a variety of reasons, companies don't want to appear or they may have missed. But it's just to show you that research is unrelenting, fortunately. I'm not including in this slide some drugs being repurposed from other indications to epilepsy, and there is hope for that as well. But there is definitely hope that with all ongoing efforts in research and the better understanding of the etiologies of epilepsy, we will have in the future drugs which are not just symptomatic, but also drugs which go to the underlying disease and will eventually even prevent or cure the epilepsy. So thank you for listening to me, and I'll be happy to answer any questions that will come up in the next few minutes.
Thank you, Professor Perucca, for this wonderful talk, very thorough and explicit about anti-epileptic or anti-seizure medications. Thank you so much. We have some questions from the audience. The first question is, what are your recommendations regarding bone density screening in patients on enzyme inducers anti-seizure medication?
Yes, it's a good question. Especially when and as these people get older, not in young age, but when you start to go above 40 or 50, I think a bone scan would be indicated, and follow up these patients because this is often a progressive condition. Of course, keep also in mind predisposing factors, because postmenopausal women would be at greater risk, and people taking some specific medications, people who do not do much exercise, people who have poor diets would be a special risk. And some of these people may benefit from supplement of calcium and vitamin D.
The same person asks, should we also measure vitamin D levels periodically on those patients?
It depends on where you live, what the facilities are, and in some settings where this can be easily done, yes, it can be done. If you have a very sophisticated laboratories and you have no issues with resources, you can even measure 125 the hydroxycholecalciferol, which is the main active metabolite. But otherwise, you may simply rely on a bone scan.
Another question. Do we have a possible explanation for the difference in teratogenicity between oxcarbazepine and carbamazepine?
It's an interesting question. Well, let me be first of all, how can I say, precise. The point estimates for oxcarbazepine were lower in terms of teratogenic risk compared with carbamazepine, but the confidence limits overlap. So we cannot say for certainty that oxcarbazepine has a lower risk of teratogenicity, but I agree the findings seem to indicate it has a lesser risk, and that might relate to, you know, a different, the mechanism by which drugs cause teratogenicity is probably not the mechanism by which drug controls seizures. So the impact of oxcarbazepine on that secondary mechanism that we don't fully understand may be less than that for carbamazepine. But this is speculation because we don't know the precise mechanism by which these drugs cause teratogenicity.
What medication would you recommend in patients with like old age onset epilepsy?
I personally would recommend lamotrigine. And the reason I'm saying this is that, first of all, there is extensive evidence from well-conducted studies about the efficacy and safety of lamotrigine in this population. Secondly, lamotrigine is not an enzyme inducer and is not an enzyme inhibitor, so it's not likely to cause drug interactions with calcium antagonists and many other drugs that these people often take. Third, we don't have to worry too much about this low titration because elderly people tend to respond to low doses. So there is already an indication from studies that 50 milligrams may be already sufficient in some elderly people to control the seizures. And it does not take a very long time to reach 50 milligrams per day, and even 100 milligrams per day, which may work in most people of old age, may still be sufficient. So unless there is a need for really a rapid effect, lamotrigine has some advantages. It does not have a tendency to induce depression or irritability that can be an issue in the elderly that you have sometimes with levetiracetam, but levetiracetam could be a reasonable choice. And lacosamide, I would also say, could be a reasonable choice too. Lacosamide also has the advantage of not being an inducer and therefore not causing drug interactions.
There's another question. So what is your experience, your current experience in patients who are pregnant with lamotrigine regarding the doses that you have to adjust? Because we see that in there's a graph where you showed that a lower dose of lamotrigine was better or was less teratogenic than a higher dose. But during pregnancy, we have to keep the doses up.
Yes.
So what is your experience?
First of all, in all those slides, the analysis was intent to treat. So the dose was the dose at the time of conception.
Okay.
I also have to say that not all studies have found a dose dependency in lamotrigine teratogenicity. For example, in the North American Pregnancy Registry, that dose dependency did not emerge. And this is not a striking dose dependency, as we have seen, for example, for phenobarbital and valproate, of course. However, having said that, the question is very important. I think emphasizes, first of all, if you live in a setting where you can get lamotrigine levels, emphasize the importance of monitoring the concentration of lamotrigine before pregnancy, if you can. And this is not difficult. Any female in whom you have stabilized, you have found the right maintenance dosage, just check a level once or twice, you have a baseline. And then when you get a phone call from the woman telling, you know, I'm pregnant, get a level right away, because sometimes early in pregnancy, the levels are already going down. And if the levels are going down by 1/3 or more, data have shown that the probability of seizures recurring and getting worse will be higher. So by repeatedly monitoring the serum concentration of lamotrigine, you can adjust the dosage and keep stable lamotrigine levels, avoiding the deterioration in seizure control or recurrence of seizures, which means losing the driving license, etc. Can be, you know, a very unpleasant experience. And if you want to do even more, it tells you how to use a drug. I mean, if in that person you have given 100 milligrams of lamotrigine, and you take a blood level, and the seizures are still there, and then you go up to 200 milligrams, and the seizures are still there, and then you take a level, and then you go up to 300 milligrams, and the seizures disappear, and you take a blood level again, and you have information about the level which is effective and the level at which the seizures appeared, were there, were not controlled. So this allows you, when that same person becomes pregnant, to tell, okay, this is the level that before caused seizures when she was on 200 milligrams. And so you have even greater incentive to adjust the dosage. So I am perhaps oversimplifying things a little bit, but basically telling you that levels of lamotrigine are very important in managing lamotrigine treated women during pregnancy. If you don't have facilities for measure levels, you just have to increase the dosage at least twice after a couple of months on lamotrigine, and then act according to clinical response.
Perfect.
And remember also that contraceptives do the same. If you start a woman on a steroid contraceptive, the levels of lamotrigine will drop. But if you take the lamotrigine level before, you know how to adjust it and by how much you have to adjust it.
Perfect.
And again, it's very different from one person to another. In one person, it may drop by 75%. In one person, it may drop by 25%. So if you don't measure the levels, you can just make a general estimate from probability from the median of the population and adjust the dosage according by guessing. But if you have the level, is a more rational approach.
Perfect. So these are the questions for today. We really appreciate you being with us, and we enjoyed your amazing talk. It was very, very interactive and very informative for us. Thank you, and see you next webinar series with more to come.
With pleasure. Thank you for hosting me, and best wishes to everyone. And let's hope to get out of this pandemic as soon as possible, wherever we are.
Thank God.
Bye-bye.
Bye. Okay, thank you so much, Prof.